Okay, everyone, thank you for joining us today on September 5th. We're thrilled to have Dr. Irfan Asif join us today on this nice September day. I'm joining from not in clinic, which I suppose many of you are as well, just joining enjoying the last weekend before everything starts up for the fall. I do want to just acknowledge first and foremost that where Western University is located on is sacred land upon which we're privileged to live and work. We recognize the deep connection and long-standing relationship between Indigenous peoples in the land of Southwest Ontario and of London. We acknowledge the Anishinaabeg, Haudenosaunee, Lenape, and Chinanton nations whose traditional lands we are gathered upon today, and we're deeply grateful to have the opportunity to be in this place. As we have been doing for all of the masterclasses up until this point, we've turned off the chat, and then we will be using the Q&A today as you have any questions that coming up. The session is being recorded, and the introduction will be followed by about a 40-minute presentation and then 15 minutes of Q&A. What we have the ability to do is, as you type your questions in the Q&A, or if you look into that box as you're going through the lecture, if there's one in particular that you like or a few that you like, make sure that you like them. It will essentially upvote those questions, and we'll be sure to answer those questions in priority sequence at the end of it. This masterclass was also developed from input from our scientific planning committee, so many thanks to Dr. Eric Wong and Dr. Sadia Jan. I have the pleasure of introducing our speaker today, who's been an inspiration to me in many ways, and specifically in terms of just the leadership that he's shown in this particular area worldwide, and is an international expert in the field. Dr. Irfan Asif is the Associate Dean for Primary Care and Rural Health and Professor and Chair of the Department of Family and Community Medicine at the University of Alabama in Birmingham. And Dr. Asif is certified in family medicine and sports medicine and has an extensive program of research that explores multiple domains within sports cardiology, and with a specific focus on the prevention of cardiometabolic disease by enhancing physical activity. So, Dr. Asif, thank you very much for joining us today, and we really appreciate your time that you'll be spending in specific expertise, particularly for clinicians, many of whom really struggle with this topic in terms of, and myself included, in terms of how can we best prescribe physical activity to our patients, knowing of all the different risk factors and stories that they come into our clinic with. So I'll turn over the mic and the presentation to you, and thanks again for joining.
Thank you, Jane, for that kind introduction. I love working with you, and really appreciate that you put on this masterclass for others to learn from. Today I'm going to talk about physical activity prescription in primary care. What do we know and where do we need to go? The disclosures for financial interest are listed here. And then for your background, I am an associate editor for some journals, and I'm on the board of several organizations and have some research funding, but none of that should present a conflict today. This presentation will have potential bias managed by ensuring that data and recommendations are presented in a fair and balanced way. Our main objective today is that by the end of this session, you'll be able to explain the importance and benefits of prescribing physical activity to your patients. So part of today is that we're going to engage in a game, and I would love your participation for those that are on the call today. Hopefully it will help you with keeping in mind the recommendations that we have. So this is the first question, and there are two ways to get in. The first is to use your phone and look at the QR code at the upper right of your screen. Or if you go to the web link on the upper left, polev.com/IrfanAsif750, that will get you into the game. And this is the first question. So this is the first question, and I'm going to click the next slide, which will give you, this is a true false, and then there'll be a leaderboard that'll show up as the third slide after every question. The questions are set up such that they prime the content that will come afterwards. So you will see the questions, and then we'll go over the answers throughout the presentation. So again, the first question is, Professor Jane Thornton is awesome. And hopefully you all know the answer to this question. You'll have 10 seconds to be able to answer. Great. 100% of the group got this correct. So the answer is true. You will get points for answering not only the correct answer, but also how quickly you respond. So you can see that although the first four got it correctly, Miterson got the answer correct, but just was a little slower in his ability to answer. It's glad to have you on here, Miterson. All right, so I'm going to talk a little bit about the United States and my experience being here. So the United States is a healthcare system where we spend a considerable amount of money in healthcare costs. And when you look at us compared to other systems, we actually spend the most amount of money. You would think that that translates to really good care. But when we look at our outcomes, according to other developed countries, you actually see that we're among the worst in our health outcomes, despite spending so much in dollars for healthcare. And you probably think, well, why is that? Well, one of the reasons is that we're in a fee-for-service model within the United States. So if you think about that in terms of a car, we're incentivized for your car to break down because we're going to get paid to fix it, as opposed to a preventative measure where you might try to prevent your car from breaking down in the first place. And so what I've been trying to do is to have people envision a system where we're not incentivizing the fee for service, but actually trying to prevent disease. And in that model of transitioning the paradigm from sick care to well care, some of the things that you might think about, so if you think about what keeps people healthy, you might envision someone who's exercising, someone who's eating healthy, someone who's sleeping or very mindful in their ways and de-stressing. Those are the types of things that we might think about to keep people healthy and prevent disease. When you look at maps, though, of where disease is occurring, so this is obesity in the United States. And for those that aren't familiar with Alabama, Alabama is located in the southeast, so it's here. And you can see that we're at the central core of where obesity is. And that map is very similar to where you see diabetes rampant in the United States, particularly in the southeast. You can see similarly for heart disease that it's more predominant in the southeast. And you can look at even cancer. So this is lung cancer, again, more predominant in the southeast and the Midwest. And if you put a map of physical activity in the United States, you'll actually see that physical inactivity really mirrors the diseases that we have within our system in the US. And so again, the burden of chronic disease and cancers parallel the distribution of physical inactivity in our country. So we know that physical activity works. It helps to prevent chronic diseases, heart disease, type 2 diabetes, many cancers, dementia, depression, and anxiety. But there's a gap between our knowledge and the implementation of this practice. And so I want you to take a moment and I want you to think about your best friend. And I want you to try to write an exercise prescription knowing your best friend. So we'll take about 10 seconds and I want you to think about what are the types of things that you might include in that exercise prescription. So let's walk through and think about an exercise prescription. So again, get your phone ready. We're going to engage in some questions, and then I'll walk through exercise prescriptions for you. So this first question is in a study titled Effectiveness of Physical Activity Advice and Prescription by Physicians in Routine Primary Care. How many minutes per week did older adults who received a physical activity prescription increase their activity levels? So is it 0, 13, 30, or 130? All right. So many of you responded with 13. So we're going to keep going with another set of questions. And again, we'll answer these questions as we go through. All right, so we've got our leaderboard. All right, so the next question is, what does FIT-VP stand for? So you have 5 responses here that you can choose from. All right, so the most common answer here was frequency, intensity, time, type, volume, and progression. Our leaderboard with Matt Neary. Good to see you, Matt. All right, according to the National Physical Activity Guidelines, what is the recommended amount of moderate to vigorous physical activity per week for adults? Again, 5 choices here. Great. All right, most of you answered 150 to 300. Let's take a look at our leaderboard. Matt is still in the lead. Abby's very close. All right, what does the Borg rating of perceived exertion measure in the context of exercise and physical activity? All right. And the answer here that most people came up with is the individual's perception of their exertion or effort during exercise. All right, so far, Abby is overtaken, Michael is in second, and Matt Neary in third. This is great. All right, so we'll walk through some of these answers here in the next segment. So this is a study that came out of Spain, and it looked at physicians who were counseling patients on exercise. And what they did is they used a 15-minute educational session, looked at the goals of the patient, tried to address their barriers and thought about solutions for them, and then ultimately designed a 3-month physical activity plan. And what they found is that older patients who received a physical activity prescription actually increased their activity level by 131 minutes per week compared to their controlled patients. And then that was actually double the minutes per week devoted to moderate or vigorous physical activity. So when I typically am counseling patients on physical activity prescriptions, I want to make sure that they can exercise first. And so I think about contraindications, either absolute or relative. And I think that Mats Borgesen, who's going to be doing the talk on Thursday, will go in more in depth with this. But 2 questions that I typically ask to make sure that people can exercise. I ask them, can you walk approximately 10 minutes per hour, about 3 miles per hour, without experiencing symptoms of shortness of breath? Or can you climb 2 standard flights of stairs without stopping because of limiting symptoms? And so if I can get these patients to answer these questions yes, then I think about writing an exercise prescription for them. And so when I write exercise prescriptions, I think about the FIT VP model. Before it used to just be the FIT model, but adding volume and progression are really important. So FIT VP stands for frequency, intensity, time, type, volume, and progression. And so when you think about frequency, typically I'll write prescriptions for about 3 to 5 sessions per week. And typically we're going to engage in moderate to vigorous physical activity. So the moderate physical activity will typically be 40 to 59% of your maximum heart rate, and your vigorous will be 60 to 89%. Most people will do 30 to 60 minutes per session, although if you do 10 minutes at a time, that has actually been shown to be effective in reducing the burden of chronic disease. But most of the sessions that we write are 30 to 60 minutes. So 30 to 60 minutes, 3 to 5 times per week. And your physical activity prescription may include aerobic, may include strength training. It may include mindfulness. It can include different types of exercises. Your volume would include your intensity multiplied by the frequency and duration. So getting a sense of how much people are exercising is important. And then thinking about the progression. And most often you'll increase the duration and frequency before you increase the intensity, particularly for those that are new to exercise. One of the things that I do is look at the maximum heart rate and try to calculate heart rate target zones for intensity. This is one of the ways that you can do it if you wanted to think about writing a prescription and looking at heart rate based on the individual. And so what you can see here is the heart rate reserve method. You can see light physical activity is 30 to 39%, moderate at 40 to 59%, and vigorous at 60 to 89%. So if I'm going to calculate someone in the moderate zone, I'm going to look at heart rate max. So that's 220 minus your age. And then the heart rate reserve method is actually taking into account your baseline heart rate at rest, as well as your heart rate, your maximum heart rate. And then it's going to be multiplying your desired intensity to get your heart rate zone. So if we were to look at this, let's say someone is 50 years old and their baseline heart rate is 80. So 220 minus the age of 50 is going to get you to 170. And if you look at the heart rate reserve method, I'm going to take the heart rate max minus the heart rate at rest, and then I'm going to multiply it by the desired intensity. So if I do that multiplied by 40%, that gives you 116 if you do this formula for the bottom zone. And then if you do the top zone of moderate at 59%, it'll get you 134. So if you're trying to get someone to exercise with an age of 50 and a baseline heart rate of 80, you're typically telling them to be at a heart rate of 116 to 134, so about 120 to 130. And so another way to look at this is looking at the Borg rating of perceived exertion. And the way that this is made is it's a scale from 6 to 20. And if you add a 0 onto the rating of exertion, that actually correlates to most people's heart rate. And so in this case, if you're going to work out in the somewhat hard zone, that's going to be a 12 to 13 on this scale, or around 120 to 130 beats per minute for your heart rate. So again, that's very similar to what we calculated for the 50-year-old with the baseline heart rate of a resting heart rate of 80. When I'm writing an exercise prescription, I talk to people about warm-up phases, conditioning, cool down, and stretching. And you can do stretching both at the beginning and end of your session. The warm-up is usually 5 to 10 minutes of light to moderate activity. The conditioning session, again, can be 20 to 60 minutes, or 30 to 60 minutes. But if you do 10 minutes at a time, that can be effective. Your cool down is 5 to 10 minutes, and then the stretching at the end will be about 10 minutes. And again, you can stretch both at the beginning and the end. There are different types of physical activity that you can do. The goal for most adults is 150 to 300 minutes per week of moderate to vigorous physical activity per week. And most of the guidelines talk about both aerobic activity as well as muscle strengthening. But a reminder that there are other types of physical activity, including bone strengthening, balance, mind, body, and flexibility, for example. If you're wondering how they came up with the 150 to 300 minutes per week of moderate to vigorous physical activity, you can see that they've done a study looking at mortality benefits, and they show a U-shaped curve here. And you can see that you start to plateau around 300 minutes. So the benefits of physical activity after that, while still good, oftentimes plateau. But that's where they came up with the 150 to 300 minutes as part of the guidelines. So we're going to have another question here. This question is, what is the most effective exercise mode for reducing resting blood pressure? So here are your answer choices. All right, so most people picked combined, followed by a tie here for aerobic and high intensity interval training. So this is really interesting. We've still got Abby in the lead. That's great. So this was a study that just came out of the British Journal of Sports Medicine, and I was really surprised by the findings. So if you look at the graph here, it actually shows that if you look to the right, isometric exercise training, according to this meta-analysis, has been shown to be the most effective at reducing blood pressure, both systolic and diastolic. And so one of the things that I've been looking into as I write exercise prescriptions is to think about isometric training. That might include a plank or a wall squat or an isometric hand grip. And an example of isometric exercise for a wall squat would be a 2-minute wall squat followed by a 2-minute of rest. And you would do that 4 times. So in total, that would be about 16 minutes of exercise. And I haven't really, as part of my prescriptions, I'm using that as an adjunct. So still trying to get people to do aerobic activity, but given that it might be a 16-minute phase for the isometric wall squat, you could actually use that as an adjunct. But again, this study just came out from the British Journal of Sports Medicine, and I think it's worthwhile to look at, and I think it's challenging the old guidelines, which typically only talked about aerobic and resistance training. So writing the exercise prescription is something that might be easy and might be more objective, but when we have people in front of us or populations at large, it's actually hard to get people to exercise, and that behavior change is really important. I know that Ann Gates talked about the 5 A's last time during the last masterclass, so we'll look at some other ways to engage with behavior change. So our next question is, what is the trans-theoretical model of behavior change? We have 4 answer choices for this one. Okay, we've got a tie for a model that highlights the influence of social and environmental factors on behavior, and a model that identifies 5 distinct changes through which individuals progress during behavior change. So again, Abby's still in the lead, followed by Miterson and Michael. So next question is, how does the confidence ruler technique, often used by physicians, assist in promoting behavior change in patients? And again, 4 answer choices here. All right, so by quantifying the patient's confidence in their ability to make specific behavior changes. Good, so let's take a look at our leaderboard. Very similar, although guess 428 is starting to creep up, so that's good. All right, so the trans-theoretical model of behavior change has 5 distinct stages. Those include pre-contemplation, where a patient doesn't have any intention to do something such as physical activity. Contemplating, so contemplation where they're thinking about something like exercise. Preparation, so they're going to be physically active in the near future. Action, and maintenance. And this is something that's been studied in the literature, not just for exercise, but also for stopping smoking, for example. So it's well validated. And the best times to write exercise prescriptions are during the contemplation and preparation phase. And if you have a fitness center, cardiac rehab, physical therapy, exercise professionals, those may be good to engage during those phases to help people envision what their exercise program might look like. Some of the common barriers that you probably encounter is that some of your patients may say they're not motivated, they don't have enough time, or they're really not sure about exercise and they have some misconceptions. Ways to overcome those include motivational interviewing, trying to set realistic goals, or trying to find ways to incorporate physical activity into one's daily routines. And so these are some different approaches that you can use to try to engage in motivational interviewing, which I know Ann Gates last time talked about the importance of motivational interviewing. And I just wanted to highlight a couple here. So one is the importance ruler. So asking some questions to assess how important physical activity might be for the person and what it might take for that person to make it more important. Or the confidence ruler, asking questions to assess the person's confidence to engage in physical activity and their confidence to change. And so when I do these, I'll typically assess that on a scale of 1 to 10, and then ask some follow-up questions to understand why they might believe if it's a 3 or if it's an 8, why so, and then what you can do to push them towards, say, a 10 if you're trying to ask them about the importance or their confidence. So one of the other things that I found to be an issue is really the medical education system, or at least that is the case in the United States. So we've learned about an exercise prescription, we've learned about behavior change, but how often do they teach this in the medical school setting? So here's our next question. So in a study, physical activity training in US medical schools, preparing future physicians to engage in primary prevention, how many hours of required curriculum did students receive in physical activity counseling? So 4 choices. Good. So the most people here answered with 8. That's great. Abby is still in the lead. Fantastic. So yeah, if you look at United States, US medical schools, the amount of required content related to physical activity. So we started the talk with how important physical activity is. It's the foundation for preventing chronic diseases, dementia, cancers, all of the above. And unfortunately, most medical schools might spend about 8 hours on their required curriculum in total over a course of 4 years, talking about physical activity. And we actually repeated a study looking at physical activity content, and we found that about 12 hours of medical student education was devoted to physical activity. Again, over a whole 4-year curriculum. And so, in my opinion, that's not enough. If you think that, oh, well, you probably get that after medical school, you probably get that in residency, it turns out that most primary care residencies only spend about 3 hours per year, or 9 hours total, looking at physical activity and its importance. So teaching residents, it really mirrors the lack of information that you see in the medical school setting. So one of the things that we did, and actually had the pleasure of working with Jane Thornton on this, was we put on a summit on exercise medicine and physical activity promotion through the American Medical Society for Sports Medicine back in 2021. And our goals there were to look at the medical education system as well as clinical models to improve exercise and physical activity promotion. We used a modified Delphi process and published this article in the British Journal of Sports Medicine. And we had leaders from our educational team, our clinical team, our educational leads across the country through our fellowship programs. We had a diversity, equity, and inclusion team, and then we also had the AMSSM Board of Directors review this. And if you're involved in medical student education, this is definitely something to look at, actually, not just for medical students, but also residents and fellows. What we have here is we have content for medical knowledge. We have practical elements so that you can actually incorporate this into the way that students write exercise prescriptions for patients. If you have students who are gunners, or that's what we call them in the US, gunners, who might be at the top of their class and want more, we actually have optional content. And then we have assessment or performance if you want to evaluate your learners. And so you can see that we've done that within the medical school setting, and our idea is that we've threaded this throughout the entire 4-year curriculum. We've actually looked at the residency education and put this in the context of our broader lifestyle medicine curriculum. And then we've also, within the residency curriculum, we really talk about healthy behaviors for patients, for community settings, but also how to make sure that residents are taking care of themselves during a busy training experience. And then the last part is really looking at the physical activity content, educational content for fellowship programs. And the way that we laid those out was in 8 distinct modules. So we have modules on exercise and behavior change, exercise and clinical practice, exercise nutrition, exercise physiology, exercise prescription, exercise testing, exercise training, and then exercise and population health. And what we did is we actually took that content around these 8 modules, and we created the modules themselves using international expertise. And so if you're interested in these freely available modules to incorporate within your own training programs, you can go to tinyurl.com/exercise modules, and you'll be able to access these for free. It'll ask you for some login information as we're trying to track who's using them around the world. And you can see that so far, over 500 people have engaged with them. These came out just earlier this year from 30 different countries. And people who've engaged with the modules say that their knowledge has increased as well as their confidence in ability to write exercise prescriptions for their patients. So I would highly encourage you, if you're interested in this talk, as well as what Ann Gates and Mats Borgeson are talking about next, I would consider looking at these modules. We also had a team from the AMSSM Summit looking at clinical practice. And one of the things that they found is that physicians, if they were to engage with patients in writing a physical activity prescription or just talking about physical activity, it didn't matter how you did it, but you increased physical activity levels. Even if you didn't write it down, you increased physical activity levels by about 30 minutes per week, which is a pretty big difference if the goal is to get to 150 to 300 minutes per week. So again, I would definitely try to talk to your patients about physical activity, write exercise prescriptions, and to help guide them. So we're getting into our last questions here. So I think this might be the last question. What does expert in healthcare stand for? And so there are 5 responses here. All right. So the answer that most people chose is screening, brief intervention, and referral to treatment. So I think that Abby is our grand winner, followed by Michael and Miterson. I will try to work with Dr. Thornton and Kristen to see if there's a way to get a prize over to Abby, but I really appreciate everyone engaging in this. I'm going to walk through some more slides to help you understand a little bit about what we do within our system to help promote exercise. So here in Alabama, we've partnered with the American College of Sports Medicine and their Exercises Medicine program. And most of our partnerships have included our local fitness centers, including YMCAs within our region. We've created a model within the electronic medical record where we use the screening, brief intervention, and referral to treatment paradigm to try to increase physical activity levels. So we screen with the physical activity vital sign, asking people how many days per week do they exercise and how many minutes. And that gives you the total that they might have, again, shooting for the 150 to 300 minutes per week. Other systems incorporate here what type of exercise. So you can include that within the exercise prescription here if you wanted to. We think about if someone's not meeting the recommended goal, how we might be able to counsel them. So sometimes we talk to people about how it might improve their diabetes control, their hypertension, mobility issues, and back pain. And then we refer them to one of our community fitness partners, such as our local YMCA. We then work with that local fitness partner to be able to send a secure message so that they get all the referrals. They don't get the HIPAA compliant. So we make this HIPAA compliant. So they don't get information about their medical record, but they're able to see what's pertinent to them in order to have them exercise. And then we also engage with our staff to make sure that they're fully prepared to understand what happens for a patient if they're needed to work with either the patient or the community fitness partner. So far, we have about 100 people who have started working within our Exercises Medicine program. Most of the people have engaged for weight management. And then you might understand some of the typical barriers that people have in trying to get to the community fitness facility. Those might include lack of social support, motivation, or confidence, lack of time or energy. Lack of transportation, I thought might be a bigger issue, but for our patients, that's less than 5% for at least our patient cohort. But we do track all of these, and we try to use that information to make our program better. So what does the future look like? We're trying to build on this expert model. And when you're thinking about the future, it's important to think about drivers of change in the world around us or within healthcare in general. And so three major drivers that are out there include next-gen professionals who have a different way of learning. So micro-learning, looking at smaller, more focused class sizes. The DEI space, so diversity, equity, inclusion, which is being increasingly seen by even the CEO level folks as strategic priorities in terms of workforce development and the work that is being done for patients. And then the last is healthcare disruption, particularly with technology. And so these are things that we try to incorporate as we think about the future for how we deliver physical activity and exercise prescriptions. So some of the things that are coming out include gamification, and I appreciate you all participating in the game that we played today. There are many games that are out there to engage people in physical activity. Some of these things are becoming even more personalized, particularly with artificial intelligence and machine learning. In our clinic, we've created the FLOW program, and FLOW stands for Fitness, Lifestyle, and Optimum Wellness. And within that, we do a lifestyle medicine assessment for patients, doing a questionnaire, understanding body composition, looking at blood biomarkers, genomics. We offer people coronary calcium scoring. We do personality and behavior assessments if people want to get more personalized prescriptions. And then we do resting metabolic and active metabolic assessments for those who are also interested. We write personalized plans. We use our Genius Bar to use apps that might be able to help patients. We try to engage with health coaching, and there are different ways to do that, either through text message, phone calls, or personal coaches. We utilize community fitness partners, and then we help to monitor and provide feedback to patients on how they're doing. This is an example of some of the ways that you can take the information that you use with wearables and have that come into the electronic medical record, so that becomes part of the dashboard that you can see when counseling patients. So this is a patient that we looked at for cycling distance and fueling. And so those are some ways that I see the future going, where you in primary care might be able to use this as part of your EMR. We do this not only within our clinics, but we also think about more broadly patients at need. So this is an example of a study that we did called the TEAM study. So tele-exercise and multiple sclerosis. And this was throughout the Southeast. We used remote platforms to try to engage with patients who had multiple sclerosis to get them to be physically active, because we found that those patients, they actually said exercise is the most sought after information for MS patients from their providers. And so we've been engaged in remote exercise, so thinking about tele-exercise programs. And we've used machine learning to try to figure out who would be best to do tele-exercise programs with. And what we found is patients do better if they're able to set and follow goals. Our patients did better if they were older in age, had higher health literacy, increased self-efficacy, and were able to interact with our health coaching program, which was through an interactive voice response on the phone. So these are some things that I think you'll see coming out in the future as far as how you might be able to engage patients in exercise. AMSSM is also committed to diversity, equity, and inclusion. And the most recent summit that we had in April was around this topic of health disparities in sports and exercise medicine. One of the things that we did was to make sure that we thought of everybody, not just your elite athletes, but athletes who may be under-resourced, who are marginalized, or who oftentimes are not thought of as being the ones who need help. And these are the ones that probably need help the most. And so we tried to challenge people in their thinking of who should be or who is an athlete. One of the best talks of the summit was by Monique Burton, and she really talked about physical literacy. So she works in Seattle, Washington, and she developed a movement clinic. And the idea here is to create equitable exercise and activity for everyone. And so using terms like exercise and physical activity in her clinic may not be the way to get people to actually move. And so she uses different ways, whether it's dancing, acrobatics, climbing, walking, performance arts. There are different ways within her movement clinic, where she's been able to engage with people from under-resourced backgrounds. And again, I thought that it was an amazing talk by Monique, really putting into context social determinants of health and how that might play a role for patients. Here in Alabama, Alabama is a very challenging state. We have one of the highest rates of obesity, stroke, cardiovascular disease, and some of the lowest levels of physical activity, fruit consumption, or vegetable consumption. One of the residency programs that we take care of is in Selma, Alabama, which is in one of the poorest cities in all of the U.S. And what we've tried to do is to partner with a community clinic there to try to mirror that exercise as medicine program that we had with the YMCA. And so this is a center where we partnered and tried to open another place because in that city, it's harder. They don't have access to physical activity or sidewalks the way that others may. At UAB, we do think about trying to be a health promoting university. I think many of you all may be familiar with the Okanagan Charter, and we signed on with that charter. And one of the things that we stressed was this exercise as medicine program. And our goal here is through that program and through something called the Grand Challenge, our goal is to try to get Alabama out of the bottom 10 to make it a healthier place to live. And some of the ways that we do that include bringing academic partners, businesses, healthcare, insurance providers, government officials, faith-based organizations, and community stakeholders to try to change policy and make physical activity more accessible for different communities. And so we have different demonstration zones here on our campus, but also in surrounding communities. If you're familiar with Birmingham, some of the poorest areas like Woodlawn, Kingston, Ensley, Bush Hills, and Eastlake are, again, some of the most under-resourced areas. And through this program, we're trying to promote physical activity, nutrition, and prevention, looking at wellness. So we have a lot of work to do in Alabama, but these are some of the ways that we're trying to address some of the issues that we have here in the Deep South. So to help conclude, some of the barriers to practice that we talked about included the knowledge of how to do physical activity or exercise prescriptions and how you might address behavior change. Some additional barriers, though, are having patients adopt what we prescribe for them and to really consider the social determinants of health and the built environment in their communities. And so my last three takeaways are that exercise is a cornerstone for the prevention and treatment of disease. I think the medical education system, at least in the US, has to do a better job of preparing our future workforce to help their patients engage in lifestyle changes and physical activity. And again, I would encourage you, if you haven't looked at those exercise modules, take a look at those because they're freely available for you to use. And then if you're going to write an exercise prescription, hopefully you learned about the FIT-VP model, frequency, intensity, time, and type, as well as volume and progression. I want to thank you all for participating today. Thank you to Abby, and congratulations to her for winning our game today. And Jane, we can go ahead and open it up for questions.
Fantastic. Thank you so much, Irf. That was outstanding. It's so inspiring not only to see that the methods that you've tried to overcome all of the challenges that are even just locally and nationally and so on, but just the improvements that have been made and the ways to be able to incorporate exercise, prescription, physical activity, counseling into our daily practice isn't actually potentially as problematic as we might think as clinicians. I mean, it's fairly straightforward, and you've laid it out so nicely. So I really want to thank you for that. It is very inspiring, I know, to all of us. And what I find really striking is time and again throughout your presentation, you've mentioned things like that patients actually do want to hear about physical activity from us, and it's almost an expectation or one of the top things that they want to hear about. And I think we often, I remember through reading the literature and also own experience in some cases of teaching future doctors on physical activity prescription, that one of the barriers is that they really feel that patients don't want to hear about those lifestyle changes, that they feel that that might be something that their perception or belief that physicians shouldn't be counseling on things like physical activity and lifestyle, in fact. But it seems to be just the opposite, that patients do actually really want to hear about it. So thank you for demystifying those aspects as well. We do have a couple of questions. We do have some time as well. So Matt Daly has asked a couple of questions. And I think he's potentially answered one of these questions as well, but I'll start with the first one because I think this is a great question. And I've heard this as well, is that in the sense of why is stretching advocated before and after? So if they don't reduce the risk of injury. So why, and you see this, that's pervasive through a lot of the guidelines in terms of adopting a practice of stretching and looking at flexibility and things like that. Why do you suppose that we have those in the guidelines, and maybe what benefits have you seen in patients when you've counseled them on it?
So to repeat, the question is looking at stretching and its benefits for physical activity. Is that correct?
Yeah, I think it's that one of that aspects. I know in some of the guidelines that we see that to stretch before and or after physical activity, or adopt some stretching throughout the week to enhance flexibility and mobility, things like that. And yeah, your thoughts on that?
So, it's interesting. We had a talk by Bert Fields, who came here to do a visiting professorship a couple months ago, and for his runners, and he was an elite runner. He actually didn't stretch when he was exercising because he wanted to sort of maximize the strength within his tendons, and he didn't want there to be flexibility because he felt like it was inhibiting his exercise. I think, though, that if you go throughout your life and you aren't stretching, you're going to limit the mobility to get power and force within everything in your body. And what I found is that if you don't have mobility, when you start to have problems, the forces tend to go into the weakest points of your system, oftentimes in your bones, that may not be best for load bearing. So the way that I was taught was your bones might be best for structure and keeping you upright, but it's your muscles that are really going to be the ones that take the power and load. And so if I don't have mobility, I'm not going to use the muscles to their full force, and I might eventually cause an issue. So for me, I try to counsel my patients on the importance of exercise. We do dynamic warm-ups, which oftentimes then include ways to stretch. So I think that having a resting stretch, a static stretch, that's good. But I think when I'm doing warm-ups, particularly at the beginning, I think doing something that's active is going to be best and give you the most mobility and probably maximize your exercise too.
Fantastic. Yeah, that's great. And Matt actually asked another question, and I do thank you, Matt, as well for this question, because I think there is something else that we can glean out of it. So it's essentially, so in his practice in the UK, he's rarely faced by people who don't know about the benefits of exercise, but it's a behavior change. And they did ask about suggesting changes. And then, of course, you'd mentioned that in your talk, but then coming back to it, I'm just curious, Irf, in terms of when you've been counseling your patients and behavior change, there seem to be a lot of different angles, as you've mentioned, a lot of different models for behavior change, a lot of different angles you can take, but maybe touching on the aspects of health equity, because you do see more challenging patients potentially, right? So that people that, I shouldn't say more challenging patients that are in more challenging circumstances that may not have access to fitness facilities, for example, or maybe they have multimorbidity, so they have several chronic conditions that they're trying to look at. Do you have any thoughts for those of us that are seeing patients who, yes, they know about those benefits of physical activity, but it may be more challenging for them to adopt those specific changes. Have you seen any elements that you would say might be the top that you've seen, or maybe a couple of top options in your personal
Yeah,
experience?
absolutely. So this is hard, and I'm not going to say that I know all of the answers. Like you, I'm trying to devote some of my work to understanding this, and what works for some patients may not work for others. I think that's part of the reason that we do things like even personality assessments to try to understand what might be best to engage some patients versus others. We're specifically looking at the Enneagram as an example. So are there ways to engage different Enneagram types? And that does play into the role of what you said of the backgrounds where people come from.
Mm-hmm.
We do ask people what are some of the factors that prohibit them from exercise in our programs, and they'd be ones that you typically might see. But I think to your point, if people are worried about working 3 jobs and getting food on the table, or doing some basic functions of life, they can't envision something that oftentimes doesn't translate to a benefit immediately. And so I think that's hard. What I do know is that the work that we do, when I spend time with a patient, if it's 15 minutes or 20 minutes, that's only a fraction of the day for them. So we have to look at ways to engage with those patients outside the 4 walls of a clinic. It's why we're including things like interactive voice response, text messaging, phone calls, things that patients opt to engage in, to see if those may be ways to reinforce healthy behaviors. We've had some success with that, but again, some populations may not utilize that, whereas others may. So it's still a work in progress, but I do believe that my goal is to create, in my clinic, I call it the spark that hopefully starts the fire, but then I need help from other professionals, other systems outside of the clinic to sustain that fire so that they can continue to be physically active. And if you can get that to within their daily activity, some of it just might be parking further away from the grocery store, so they increase their physical activity. But it is a negotiation with patients. But I think if you don't bring it up in the clinic, you can never find that middle ground where patients may be able to engage with you. And I think that's the most important thing that I want you to take away from today's talk.
Fantastic. Yeah, I'm also, it's really interesting to see the flow program, because I think that idea of not just targeting physical activity behaviors, but looking at the whole picture, because if someone's not sleeping, for example, it may be hard for them to prioritize extra physical activity during the day, or as you said, working 3 jobs, that kind of thing. So it is that aspect of tailoring physical activity somewhat. And I think in my experience, it seems that, so when we talk about tailoring, then it becomes harder, but in fact, it's really that shared decision making, or a bit of that conversation with the patient in front of you, just to say, yeah, your preferences, what your abilities are, your opportunities are, and so on. So I really like how you're framing that whole that holistic approach, I guess, looking at the whole patient, in the sense of trying to understand where that physical activity kind of lies on that spectrum. That's great. And one of the things, and I don't know if you have an answer for this, but I struggle, I think, with one of the aspects of the physical activity prescription particularly is in talking about resistance training in particular. So counseling on things like, particularly those that don't have any experience with weight training at all, or what does that look like? So I think resistance training, to some, when we start introducing it for the first time, they may think that they have to now go to the gym and do deadlifts or heavy squats or leg press, and that vision comes into their mind and thinking, I can't do that. Whereas I've seen some really innovative videos where people are using maybe soup cans or resistance bands or things like that. Just curious, and maybe it's not the novice or the new person with resistance training, but how have you seen successful ways of counseling on resistance training, or those kinds of resources? Or do you mainly say kind of outsource potentially to an exercise professional?
Yeah, that's a great question. So we do exactly what you're saying. So in that team study, just an example, we did send exercise kits to people in their homes. They included some resistance bands, so a yoga mat, yoga block. And you're right, you can use, if there are cans at home or something, if you want to use light weights. And then we were able to we had pre-recorded videos that we could send to people to help them with their exercise programming. So, and they could watch the videos at their leisure. We were trying to monitor how many people actually engaged with the videos. So we're still looking at that piece. But some of those things, you're right, they're not deadlifts or, bench press, but they're things that you can just do around the home. And for a lot of our folks, that actually was more successful in getting patients to exercise.
That's fantastic. That's great. Well, I want to finish off maybe with one other question, if we have it, just in the sense of medical education, because I know it's such an area of interest and passion for you, and also the fact that you've been leading so many of these initiatives to try to increase and improve medical education on physical activity counseling. And it's interesting. I mean, on the Canadian side, we do have very similar issues in the sense of dedicating time in the curriculum to physical activity. And in terms of even, what does that look like from a time perspective, maybe, especially as we've changed curricula oftentimes where it's more competency-based versus particular set hours. And one of the other things that in Canada is that we don't have a specific set structure of curriculum. It's every medical school, and we have about 17 of them. They essentially adopt their own curriculum style and things like that. So I'd just be curious as we end off in the last minute or two, the sense of what you've seen as being successful in the US potentially in terms of adopting physical activity in the curriculum. Is it a set curriculum? Is it going based off just offering resources like you've done? And I think we'd like to highlight your link in our show notes or to follow up to the registrants and essentially show that link again, because it's excellent in terms of the exercise modules. Anyway, just curious on your final thoughts on that.
Yeah, so the medical education system is hard. I'll speak from the US side because I've been involved with some of the accreditation. There's so much to learn, and the amount of time and space that you have to wiggle into can be hard. So I think if your goal is to go in and to create some another block of content and to fit that in, I think you're going to end up with a challenge. I think the first thing that you need is you need a plan. I think you need a plan and you need some champions. And within our medical school, we've identified who those champions are. Some of those are in our department, but there may be others in orthopedics, physical medicine and rehabilitation, those who do obesity work. You can get other people to join on board. But the idea that we used was to say, okay, you have a case. Your case is with it that you're already teaching. You're already teaching about coronary artery disease, for example, in the cardiovascular block, or you might be talking about pregnancy in the the pregnancy in the OB block, for example. So what we do is we try to simply go and say, would you be okay writing, if we ask people to write an exercise prescription for a patient in one of those cases? And we hand them the case so that they don't have any extra work to do. So really it's the buy-in of, is it okay? And then we provide them with that content. And then because I'm in charge of the family medicine block in the third year, and then the ambulatory acting internship in the fourth year, we then have our students actually write some of those exercise prescriptions in practice. And so those are some of the ways that we build it in so that it's not a burden to the entire system. But we've seen some success with that. But you still need champions to be able to do that. And I think wandering around, figuring out who those champions are part of the successful ingredients for this formula.
Wonderful. Thank you so much. I want to thank you again. And we're at time right now. Maria has asked a question, which I'm going to ask Maria, Maria Sarabia, to either we're going to answer it offline or we might save it until Thursday. It was just about the controversy in Spain about the professional, who has to be the professional to prescribe exercise to patients. So I think that's an excellent question. I hope we can answer for you next time. Or we're going to bring Dr. Asif back for another talk as well, because I think it's an excellent one. And I thank everyone for joining today. You're going to be sent an email containing a link to the participant evaluation survey tomorrow. So please take the time to complete that survey. You also have the option to indicate whether or not you need a certificate of participation. So if you click yes, you'll be directed to another link to input your email so your evaluation remains anonymous. And alternatively, you can reach out to our research coordinator to receive a certificate of participation. So please email us with any answers or questions or concerns, sorry. Our research coordinator's email was sent in the registration email. So that's at Kristen. And she will be putting it into the chat as well. So again, thank you. I hope many of you can join us in 2 days as well as we go to step 2 of this with Dr. Björgensen from Sweden, who's going to be talking about physical activity prescription in primary care, but some of the nuances as well. And I just, again, want to thank you so much, Dr. Asif, in terms of a really exceptional talk and really inspiring to hear about all the work that you've done. So until next time, and thanks again for everyone joining. You're already getting many thank yous throughout the chat. So thank you.
Thank you, Jane, for inviting me. It was great seeing everyone. Thank you.